Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Healthcare du Jour is sponsored by SA Ignite, the law offices of Miracle Connell, and the Compliancy Group. And now here is your host, Matt Fisher.
Welcome back, and thank you for joining us as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On our menu today is Lucia Savage, the Chief Privacy Officer at the Office of the National Coordinator of Health Information Technology. Welcome, Lucia.
Hi.
So thank you for joining today. And for people who maybe aren't so familiar with you, could you give us a little bit of your background and what you did before you went to ONC and now what your role at ONC actually entails?
Sure. So I have been working on HIPAA privacy-related items since the law actually took effect in the late 90s. And my first HIPAA implementation was for the employee welfare benefit plans at Stanford University, which is a complicated, obviously, academic setting plus a hospital setting as well. From Stanford, I moved to San Francisco and worked 5 years at an employer healthcare purchasing coalition, Pacific Business Group on Health, where about 3/4 of my time was spent as the general counsel for the old California Insurance Exchange, which was called PAC Advantage. That was all before the Affordable Care Act. And as we had to close that exchange, it was not a good risk pool, we'll put it that way. I took a position at United Healthcare where I had a portfolio as a senior associate general counsel managing and strategic planning and negotiating relative to data transactions for health information exchanges, all payer claims databases, measurement and transparency projects like the RWJF, Aligning Forces for Quality Projects, Qualified Entity Program, et cetera. And I left United in October of 2014 to come here to ONC.
And at ONC, you're the Chief Privacy Officer, right?
Yes.
So within ONC, I think people have probably heard of, the privacy officer in the HIPAA context, but what does your role cover at ONC? Because I'm guessing it doesn't mean you're overseeing ONC's compliance with the privacy aspect of HIPAA.
No, actually one of the best parts about my job is that ONC actually doesn't manage any protected health information at all. So my position was created when Congress enacted HITECH and sort of created the Meaningful Use Program, created the Certified EHR Technology Program, and I have sort of 3 basic roles, and I supervise a team of 12 substantive people and 3 operations people. So one is I am the core privacy and security advisor for the national coordinator and on up the food chain to the secretary's office. And my job is really about explaining and making sure that the right privacy standards and principles are built into our health IT policy making and rulemaking. So an example on the security side that people really, it's really tangible is in our first rulemaking in 2011, we required that certified EHR technology have a timeout feature. So in the private sector, people are probably very familiar with timeout features on IT systems, but it was not something that had been previously required of health IT, so we required it as a technological default. An example on the privacy side would be, putting the data segmentation for privacy standard as optional in our most recent rule so that organizations that need to segment one type of data that might be subject to special rules like substance use data or sexually transmitted disease data have a technical standard for reflecting that in the data itself.
Right.
That's a key thing is the rulemaking. Secondly, we do a lot of education, so I work very closely with the Office for Civil Rights. That is the actual HIPAA regulator. I can't recall, but I think Devin McGraw has been on your show, but Devin, of course, is a colleague. My job is to take OCR's rules and bring them to life in a health IT environment. And then thirdly, we have a very big portfolio which is coordinating and collaborating not only with the private sector, but with other governmental agencies and with international other countries as well on issues related to health IT, privacy, mobile health apps, cybersecurity, et cetera.
Yeah, I'd like to pick up on the middle role that you described, which is the education. You're right that Devin has been a guest on the show, and we talked about HIPAA educational efforts with her, and it certainly seems like I'd say maybe since the beginning of the year and maybe a little bit towards the end of last year, it seems like the coordination and collaboration between ONC and OCR, there's been a lot of material trying to educate and make sure people understand the fundamentals of HIPAA that have been coming out. Is there a particular reason why all of a sudden there seems to be so much more of a push on the educational front?
I think the big reason from ONC's perspective is we're really trying to tackle interoperability, and we had a few observations about that, many of which are set out in detail in our final roadmap. But the core privacy observation was that we felt that HIPAA was well designed in a media-neutral way to support the policy needs articulated in high tech, and for whatever reason, in the wake of high tech, as we went down the path of digitizing the healthcare system, people forgot that, and they thought there was something special or different about the HIPAA privacy rule with digital information, and there really wasn't. And so we wanted to do a lot of education on what we call the HIPAA basics so that we could identify actual problems that need to be solved. HIPAA is not really a barrier to interoperability. In fact, our take on it is that HIPAA's privacy rule actually supports interoperability, and if we want data to move where it's needed for patient care and for learning, we have to take advantage of the rules we have. Once we do that, once we shine the light on what the rules actually are, it also helps us focus attention on where the rules are, in fact, if there are rules that are impeding interoperability, what can we do about that? So we want, it's kind of a both and. Let's take advantage of what we have, and let's use that process to identify problems that actually need to be solved.
Right. I think that's a very fair point, that there's either misperceptions about what HIPAA does, or I hate to say it, but either maybe deliberate disregard for trying to be able to wrap your head around what it actually does.
I think that's right. I mean, from my perspective, HIPAA is, the privacy rule in particular I want to focus on, is kind of beautifully designed to work in a wide variety of media and environments. I think that as data got digitized and as we acquired the Internet of Things in healthcare, or achieved the Internet of Things in healthcare, people rightfully wanted to make sure they were still doing what was the minimum required. And there are definitely some very vocal members of the healthcare population, 340 million Americans, who are adamantly very, very private people. I don't think that's the vast majority. The data tells us that most patients expect their data to be exchanged already and are kind of puzzled when it's not being exchanged. Right. But there are some people who are very private and really want to directly control their data, and so we hear all of that in the feedback we get from the field.
Yeah, so kind of in terms of that feedback and trying to make sure that people understand how the data can flow, and that HIPAA shouldn't be a barrier, and in fact, as you were suggesting, and I agree with, should actually be encouraging interoperability. When you were in the private industry before joining ONC, I think you said you joined ONC in 2014, so you were there, as some of these things were starting to happen in the private industry. Were you seeing at that time where some of these barriers might be getting erected, so you'd have kind of almost an insider perspective in terms of how to go about addressing it once you went to ONC?
Absolutely, and I'll just give you one anecdote. This is actually sort of a timely anecdote as we think about delivery system reform and alternative payment models. I did have a portfolio supporting how data could be moved in support of accountable care organizations and medical homes and that whole universe of activity. And what I observed was a lot of kind of excess business associate agreements, two providers contracting with each other as each other's business associates, when clearly the rules, now I'm going to get a little technical, but I know you have a legal audience, 45 CFR 164.506, it's very clear that two providers can exchange data without having to be each other's business associates. And I remember very clearly talking to a colleague in another organization, and she had called me to ask me about this, and I said, why would you make a provider organization your business associate? Then you're just going to absorb contractual liability for them. So that's my personal anecdote. That's very legal in nature, but you can see, I hear in my voice, I'm a little bit passionate about let's let's use paper where we need to, but let's not use paper where we don't.
Yes, no, I have similar discussions with some of my clients of saying, why are we trying to put a business associate agreement in place here? I agree, it's just, as you said, creating potential contractual liability in between parties where you don't need it, especially because oftentimes with the business associate agreements, I see so many provisions in there that are not required by the regulations.
Well, I mean, it is a contractual document, right? And so there's a point at which the organization that has the legal responsibility for the data, the covered entity, really has to do what they think is right for it. And I don't want people to think business associate agreements aren't required. They're very specifically required for many, many circumstances. I just think that we have to be very careful and judicious that we don't, to study the rules, and I learned all of this by opening the rule book and reading them. Study the rules and see if those rules help us accomplish what we're trying to accomplish in terms of changing the way the health information system works.
Yes, no, I definitely agree with you. And I think, as you just said, you need to study the rules, and that, obviously we're just talking about HIPAA, but, as you and I and probably most of the people listening know, there is a whole host of regulations impacting healthcare, and you always have to go back to those rules. You can't just try and do anything by memory or guess at it, because there are, the rules do become so complex that, make sure you fully understand it, and especially if you're able to focus on a particular area, go back and really study and, have them ready at hand. I keep a binder behind my desk with my HIPAA regs, and every time I have a question, I pull it out. Even if I do know it, I would want to verify, and then because you always want to make sure you have the wording exactly right.
Exactly. Well, I had a law intern this summer, and he brought a problem to me, and I said, well, go look at this page of this final rule preamble, and he said, you're right, it's right there in the third column, and I said, yes, it is.
Yeah. Yes, I don't keep my I don't keep my Federal Registers printed out. I have all those saved on the computer, but you're right, you have to have all that ready at hand, because it's while I do like that there seems to be more guidance coming out on HIPAA, you do always need to go back to the Federal Register, to the preambles, to get a lot of the thoughts and kind of the contemporaneous ideas of what's going on when the regulations are implemented.
And if I could just make a pitch, I think that, lawyers are specially trained to take new facts and apply them to old rules, right? That's the basics of the legal method. And I think that that's one of the reasons I wake up every morning excited about health IT. I'm sort of like, what are the new facts I'm going to have to deal with today that I wasn't thinking about yesterday? And I think that, a really creative and a lawyer who's really passionate about doing their job well should be able to do that, take the new facts. The technology is giving us new facts every single day, faster than we can really keep up, but we have to try and keep up. And the rules are actually flexible and scalable, to quote my OCR colleagues, and quite amenable to having new facts applied to them.
Yeah, and you pretty much read what I was thinking in my own mind as you were saying that. Especially when you're looking at HIPAA, I agree with you. They are very flexible rules, and it's kind of what you just said is a nice way to kind of shift the conversation a little bit to the report that I believe was jointly done by ONC, OCR, and the FTC that came out last week, talking about arguable gaps in the coverage of HIPAA and other related laws. So for people who maybe haven't had a chance to read, would you be able to give a quick high-level summary of the findings that were in the report?
Absolutely. The first thing I have to clarify is that it's actually an ONC report. So the congressional request was for us to collaborate with OCR and FTC, which we did very, very deeply. But the official publishing agency is ONC, and I don't want people to attribute things to the FTC that they haven't said. They have very specific procedures for publishing reports, as would OCR, which is not to say we're not all well collaborating and agreeing on that report, which is the process we went through, but it's officially an ONC report. So the second thing I'd say is that we had a blog. Karen DeSalvo and Jocelyn Samuels did a joint blog that was published last Tuesday morning, so that has a great written summary for people who want to go back to it, but I'll give my kind of a tall elevator speech, but my elevator speech. We sort of we were looking at gaps in the differences between the way HIPAA regulates health information, privacy, and security, and the way health information, privacy, and security is regulated for digital health information that's happening outside of HIPAA. We did place some guardrails around that, and we really focused on mobile health apps and exercise trackers and social media that's specifically about health status versus, say, casual social media like, what you might say on your Facebook post, or things like GPS from your phone correlated with pollen counts. That latter is really not in scope for what we're trying to reach to. And we identified 5 key gaps. One is HIPAA, as you will know if you've been paying attention to what we in OCR have been doing for a year, has a very robust right of a person to access and get a copy of and force the transmission of their health data where they want it to go. That legal right does not exist outside of HIPAA in any organized way. There might be rights that apply because of terms of service for an app, but it's not a statutory or regulatory right. Secondly, there is a difference in the ways the security conditions are manifest. So HIPAA has the security rule with its administrative, technical, and physical requirements and evaluations of how those requirements are met in kind of a process way. There isn't a security legal minimum outside of HIPAA. There's definitely, security hygiene and good security engineering, but there's not a statutory requirement about what that has to yield. Thirdly, there are definite differences in what a HIPAA-covered organization can do with identifiable data in terms of sales of that data or marketing to the people reflected in the data. There are prohibitions on that. Outside of HIPAA, there aren't any. There, again, terms of use may implicate it, but they're not statutory limits. Fourthly, consumers are just confused. People tend to think that they're familiar with HIPAA. They tend to think that it has a much wider reach than they might otherwise imagine. And lastly, we think the confusion is really impeding innovation because we hear from developers all the time, but I don't understand the difference between X and Y. And we've done a lot of work this year with this report, with the navigation tool that's on the FTC website that we collaborated on with other materials to help sort that out for the developer population. But it's so important for us to let this economic activity grow in an appropriate way and still protect people's privacy and security, that there definitely, this confusion with consumers and confusion with developers is probably hampering innovation.
Yeah, I agree. The confusion is a very good way to phrase it, and it's, I think both the consumers who are accessing these tools and the developers, certainly who are creating them, have a hunger to really get it right. I don't think anyone's out there trying to, the vast majority are certainly not out there trying to do something wrong. They just want to make sure that they're fitting into the right scheme. And I think that because of that hunger, a lot of the materials that have been put out have been very well received. And, I think it's helping a lot of people in the industry to understand what direction they need to go in and help refine the questions that they're asking.
I think that's right, and so, just to riff on that a little bit, obviously the most recent is this report that we issued on the 19th, but prior to that, we helped the FTC put together this, website that helps the developer navigate to the guidance that's applicable to their particular product. We've done a lot of collaboration in the mHealth space, soliciting input this year for a refreshed model privacy notice so that when we pull that across the line, developers will be able to have some standard privacy disclosure language in their products so that if they choose that language, it will reflect doing the right thing. Obviously, that is all voluntary on the developer part. And various other activities with the consumer access videos to help consumers understand what their rights are and how those rights play out in this digitized health world, right? This isn't photocopies and manila folders anymore. At least we're trying to move away from that.
Yes, yeah, and I think the point where you just said, some of these things are voluntary. I'm finding as I talk to some of my clients who are, these mHealth app developers or other solutions, even once we go through the analysis and, if they fall outside of the HIPAA scheme, they still recognize that there's, kind of that consumer expectation that certain standards are going to be followed. So I'm finding that a lot of companies are deciding to use HIPAA as baseline regardless of whether or not it applies. And I think that does help to establish some trust and confidence on both sides in terms of what's being developed out there.
I hope so. I think it's, at the end of the day, it's all about being transparent with your customer. And I will share with you a little anecdote from my own, this is way before we did the most recent report, but talking to a developer audience, and I was sort of making this point, like at least just tell people if you're going to sell their data, right? If you're going to monetize it, just tell them that straight up. And I got a tweet back saying they already know it's being monetized because the app is free. And I tweeted back, no, they get a free app from the bank because it saves on teller costs and banks don't sell the data. So we have to think about the context in which the consumer is getting the service offered to them. That is what's going to inform their knowledge.
Yeah, no, I think that's a very fair point. It's, you know, and especially as so many people will just install apps and never, you know, never either look at the terms of service, or, you know, you're downloading something on your phone and you're given, you know, you can either get something emailed to yourself, or you can scroll, you know, screen after screen of, you know, what's honestly very technical legal jargon. You know, no one's paying attention to that. I know, you know, at least on the legal side of things, that's been an ongoing debate for many years in terms of how do you handle the either the shrink wrap or these click-through licenses that you're being forced to go through.
Correct, correct. But on the other hand, Matt, you know, we also have an environment where we definitely regulate businesses. Certainly HIPAA regulates businesses, but we don't regulate what private people do with information about themselves. I just sent a Twitter note last week to a guy in the UK. We don't regulate what grown-ups do with their health data. You can do anything you want with your health data. We hope you don't do something foolish. But if you wanted to do something foolish, nothing stops you from doing that because we don't regulate you. And so that's where this idea of sort of work, hopefully we'll figure out some way to do in the future, no promises, but helping the consumer understand what good privacy practices are so they can pick for themselves what's right for them.
Yes, no, and that's a great way to wrap it around, which is, you know, and I think seems to be part of the debate, especially, you know, that I see bubble up on Twitter at least, which is, you know, people just want the ability to decide for themselves and figure out how their data is going to be utilized.
Yes, they do, but I also think we have to recognize that behavioral sciences tell us that, you know, inertia is one of the strongest psychological forces known, and especially when people are confronted with choices, people are very bad about making choices. And so we have to set up an environment where, on the one hand, people who are really activated and want to do stuff to manage their data, eventually, this isn't going to manifest in 2017, that's for sure, have the ability to do so. And at the same time, for people who don't want to do anything, or who are in fact in a health crisis and their attention should be on their health or the health of their loved one and not their privacy settings, information still moves where it needs to go for their care, sort of getting back to the first principles of ONC, right? If you have an accident in a place that's away from your home clinic, but you have an important medical condition, we want the doctors at the site of that accident to have access to that medical information so they can help you get better.
So as you're bringing the conversation back to interoperability, are you seeing improvements within the industry in terms of how the data can flow? 'Cause, you know, obviously we know that, you know, interoperability has remained a buzzword for the past couple of years, and oftentimes it's very hard to be able to determine if any progress is being made.
You know, our data, we just released some new data about hospitals who are interoperating and trading with each other, and I think that data is trending in the right direction. That's not really my expertise, so don't have it at my fingertips, unfortunately, but it is all on healthit.gov. But I think we still have more to do. I think precision medicine gives us an opportunity to do a lot of field testing and take those learnings from a really important but narrow set of use cases for precision medicine and apply them to a wider setting. We have our Think for Science project, which is really going to be testing the ability of APIs to move the data where we want it to move for precision medicine, and if those test results are good, that gives us a good argument for why people should keep using the technology we've already written into our rule.
Right. Yeah. No. I think that's, you know, as you said, things are changing, and it's you know, I think as long as the pressure remains there, I honestly maybe I'm too optimistic, but I do think the industry will get there. So I guess. Oh, sorry. Go ahead.
I was going to say, and we have to recognize, right? There are going to be physicians who don't want to be in a digital environment, and there are going to be patients who don't want their data record kept digitally, and that's going to happen. Just like, you know, we have people who use online banking and people who stand in line on Saturday at the teller. People have those choices, and they choose businesses that help them run their lives the way they want their lives to be run.
Yes, as we're starting to come towards the end of our time, I do want to bring up one other topic which relates to interoperability, which is the idea of information blocking, which seems to be drawing fairly differing views from certain people in the private industry, where it's a made-up issue, and the view from OCR or ONC and others in the government that view this as a major sticking point. So I didn't know if you had any thoughts that you could bring on that topic.
Well, sure. I mean, I think that in the same way that I talked about sort of our HIPAA basics for interoperability, the information blocking is a piece of that. In our blocking report, which is now 18 months old, we on purpose wrote an illustration related to privacy because we knew from anecdotes and data that people were failing to exchange information in a way that they could have legally with the excuse provided, I can't due to privacy law. It's happened to me. It's happened to my loved ones. Don't pick a privacy fight with me in the field. And so we wrote that illustration on purpose, and we used it. We have used that concept over and over again to inform our HIPAA education. What we want people to do is to have, if in fact there's a privacy law that says you can't exchange, absolutely comply with it. But if there's not a privacy barrier to you sharing with the other physician that your patient goes to, please don't use HIPAA as an excuse. There might be other reasons you don't share, but don't call it privacy when there's in fact not a privacy barrier.
Yeah, no, I agree. And I think at least it feels like some of the where the debate is coming up is either not thinking about the nuances to information blocking, or trying to look at a different look at a piece of it that doesn't touch on the privacy restrictions as you're talking about. 'Cause, my wife is a physician. She's asked me questions, and I just shake my head, going, I don't know why people are trying to throw up barriers where they are, especially when it is, you said, the provider to provider side.
Right, exactly. And Matt, I know we're running short on time, and we didn't even get to security. So we'll have to arrange that for another day because we've been pretty busy on security too.
Yes, no, that is a very good point. And I'm thinking once we start getting some of the results from the audits, that OCR is running, that should give some good fodder for security, since the risk analysis is consistently a big problem when it comes to HIPAA compliance.
Well, we have some great tools for organizations to do their risk assessments and then identify the places they need to remediate. Our security risk assessment tool, and we'll be updating that in the very near future, so I hope people use that. It's free, taxpayer prepaid on healthit.gov, but there's so much more to it than just that. Even security hygiene, educating your patients, engaging in threat sharing with other stakeholders in your industry, all of that stuff is stuff we're working on at ONC.
Yeah, and that is a great way, I think, to wrap it up, because unfortunately we are out of time. And I certainly will take you up, and maybe we'll get you and Devin on together to do another deep dive discussion into HIPAA. But I really want to thank you for joining today and for a very great and fast-flowing conversation.
Well, thank you for having me. I appreciated the invite, and I look forward to talking with you again in the future.
Yeah, no, thank you again. Thank you to everyone for listening. Keep the dialogue going and connect with me at #HCDEJURE on Twitter. I'm Matt Fisher. Until next time.